common discomforts of nausea, a backache, swollen ankles, and the inability to get up gracefully from a chair. Yet there are some problems that can arise, and they must be recognized and treated quickly to optimize the health of both the mother and baby. Spontaneous abortion, or miscarriage, is extremely common in early pregnancy. In fact, between 20 and 50% of pregnancies are lost within the first 7 weeks, usually before the woman even knows she is pregnant. The most common cause is chromosomal abnormality that is incompatible with life. Risk factors include age less than 20 or over 30 years, with spontaneous abortion occurring most frequently after age 40, history of miscarriage, recreational drug, cigarette, or alcohol use, exposure to toxins, hormonal imbalances, reproductive abnormalities, infection, chronic systemic conditions such as diabetes, congenital heart disease, or severe kidney disease, altered immune response, and maternal obesity. Iatrogenic-induced causes include amniocentesis, chorionic villus sampling, and medications such as Accutane. Many women experience vaginal spotting or cramping during the first trimester. However, bleeding and cramping together, passage of clots, or severe back pain may be signs of miscarriage. When these symptoms appear, the woman should immediately call her healthcare provider. She will examine the mother to see if she is still pregnant. Evaluations include a pelvic exam to assess her uterus and cervix, an HCG, and perhaps an ultrasound. If the pregnancy is intact, the woman will probably be sent home for bed rest. However, if the fetus is expelled, she may need a dilation and curettage, or D&C, in which the cervix is widened so that the walls of the uterus can be scraped to ensure no products of conception remain. Post-procedure, the woman will need to rest and be watched for hemorrhage. She will usually be discharged from the hospital after the anesthesia wears off and her condition is stable. Many women who have a miscarriage, as well as the baby's father, will grieve over the loss of the pregnancy, so emotional support for them during this time is critical. An ectopic pregnancy is one in which the fertilized egg implants outside the uterus, most often at the distal end of a fallopian tube. Risk factors include a history of sexually transmitted infections, pelvic inflammatory disease, endometriosis, past ectopic pregnancies, damage to the fallopian tubes, use of an IUD, or in vitro fertilization procedures. The primary symptoms are heavy vaginal bleeding and intense lower quadrant and pelvic pain. The woman should contact her healthcare provider if these signs appear. The mother may also feel discomfort in her shoulder. This is referred pain secondary to significant abdominal bleeding, which, if not quickly managed, can lead to shock. Therefore, medical care is needed immediately. Her provider will order an ultrasound to confirm the diagnosis of ectopic pregnancy, as well as the location of the implanted embryo. Medication may be administered to women who are clinically stable to halt the growth of the embryo. However, hospitalization and surgery are most often done to remove the embryo before the fallopian tube ruptures in order to prevent hemorrhage and shock, as well as save the tube and preserve fertility. If the fallopian tube does rupture, management includes cardiopulmonary monitoring, administration of oxygen, giving isotonic solutions and/or blood to maintain hemodynamic stability, and preparation of the mother for immediate surgery as she is at risk for severe shock and possibly death. In addition to helping her recover from surgery, this mother will need care and emotional support to deal with the loss of her baby. Rh factor is determined by the presence of protein surrounding the red blood cells. If the protein is missing, blood is labeled Rh negative. If an Rh negative mother is pregnant for the first time and carrying an Rh positive fetus, her body will react to this protein as a foreign substance when she is exposed to the fetus's blood. This usually happens during delivery. The woman's first baby is usually not affected by this incompatibility, as he or she is born before maternal antibodies begin to develop. During subsequent pregnancies with Rh positive babies, the mother's antibodies may cross the placenta and attack the fetal erythrocytes. This can cause hemolysis of the baby's RBCs, which in turn can lead to severe fetal anemia and even stillbirth. Because these conditions may be life-threatening to the baby if severe enough, intrauterine transfusions or preterm delivery may be necessary. For this reason, all Rh negative women are given RhoGAM at 28 weeks to prevent the buildup of antibodies. It is given again after birth if the baby is Rh positive. It should also be noted that this procedure must be repeated with each pregnancy, including those that end with loss of the embryo, fetus, or stillbirth. Gestational diabetes, or GDM, usually develops in the second trimester as pregnancy hormones interfere with insulin doing its job. Risk factors that contribute to its development include maternal age over 25, a family history of diabetes, being a member of an ethnic group prone to diabetes, or having multiple miscarriages or an unexplained stillbirth. Other common maternal factors include hypertension, being overweight or obese before the pregnancy, or having previously given birth to a baby larger than 9 pounds. To diagnose gestational diabetes, a glucose tolerance test will be given between 24 and 28 weeks. At that time, if the fasting glucose is 92 milligrams per deciliter or greater, the 1-hour value is 180 milligrams per deciliter or more. Or the 2-hour level is at or above 153 milligrams per deciliter, gestational diabetes is diagnosed. There are usually no symptoms associated with gestational diabetes. However, some women retrospectively report blurring of vision, fatigue, some nausea and vomiting, or increased thirst or urination, things they just attributed to the pregnancy itself. When the diagnosis is made, there are some changes in prenatal care. Office visits will become more frequent. The mother will also have to check and record her capillary glucose often during the day. Ideally, she would like to maintain a fasting level of less than 95 milligrams per deciliter and a 2-hour postprandial value less than 120 milligrams per deciliter. Management of GDM is first done with diet. The mother is encouraged to eat moderate fats and proteins, complex carbohydrates, and reduce her intake of sugars. If her serum glucose remains high, insulin will be needed as hyperglycemia can increase the woman's risk of complications, as well as necessitate an early delivery or cesarean birth due to the fetus being large for gestational age. Placenta previa is a condition in which the placenta grows in the lower part of the uterus and covers all or part of the cervical os, or opening of the cervix. It often becomes apparent near the end of the second trimester or beginning of the third. Risk factors include older age of the mother, smoking, current pregnancy with multiple fetuses, physical anomalies such as an abnormally developed uterus, uterine scarring from a surgical procedure, and previous cesarean deliveries. Numerous pregnancies can also precipitate the condition as the placenta tries to find unused sites on which to implant on the uterine wall. There are several types of placenta previa. A low-lying placenta extends into the lower uterine segment, but does not reach the cervical os. Marginal previa occurs when the placenta touches the cervical opening, but does not cover it. In partial previa, the placenta covers part of the cervical os. And in complete previa, the entire cervical opening is occluded by the placenta. Symptoms of placenta previa vary. Usually there is a sudden burst of blood expelled from the vagina. Some women have no pain. Some have mild cramps, and yet others report severe discomfort. Women should be instructed to contact their healthcare providers immediately if they experience any of these symptoms. Assessments include palpation of the uterus and evaluating vital signs for symptoms of significant blood loss. It is critical, however, that a pelvic exam not be performed, as it can provoke more intense bleeding. Definitive diagnosis is made with ultrasound. Management of placenta previa depends on the amount of bleeding, how much of the cervix is covered, and the maturity of the fetus. If there is a partial covering, the woman may be placed on bed rest or have her activity restricted. If bleeding continues or increases, she may be hospitalized for monitoring, transfusions, and medications to control the hemorrhage. If her condition stabilizes, she may be given drugs to continue the pregnancy until the 36th week. Vaginal delivery at that time may be possible, but cesarean is preferred. If bleeding cannot be controlled, the woman will have an emergency cesarean delivery and be given transfusions as needed. Placental abruption is the leading cause of hemorrhagic death in pregnant women. In addition, this condition is the leading cause of fetal death. Those babies that survive are at risk for respiratory distress syndrome, anemia, and neurological deficits as a result of decreased placental perfusion and/or preterm delivery. Placental abruption occurs when the placenta separates from the uterine wall. It may result from trauma, sudden decrease in uterine volume after loss of amniotic fluid, or after the birth of the first twin. However, many times the cause is unknown. Some women are prone to this condition. Mothers with chronic pathologies such as clotting factor disorders, diabetes, hypertension, and uterine fibroids have a high risk, as do women with a history of previous abruption and numerous births. An abnormally short umbilical cord, premature rupture of membranes, or increased uterine distension, such as from multiple fetuses or a large amount of amniotic fluid, may also precipitate abruption. Older mothers and those who smoke, drink excessive amounts of alcohol, or use cocaine are also more predisposed. Often the first sign of abruption is dark red vaginal bleeding. Cramping, abdominal pain, and sustained increased resting tone and tenderness of the uterus may soon accompany this. There may be back pain as well. As with other sudden episodes of bleeding and pain, the woman should contact her provider immediately. Assessments will include checking her vital signs, evaluating pain, and palpating the fundus. Checking fetal heart rate is also critical. Treatment depends on the degree of abruption and can range from bed rest for mild abruption to emergency cesarean delivery if there is maternal hemorrhage or signs of fetal compromise. If there is fetal death and bleeding is controlled, labor will be induced. The mother must be prepared emotionally and physically for this process, as it will be extremely difficult for her. Grief counseling by a social worker or pastoral care should be available both to her and the father of the baby. Pregnancy-induced hypertension, or PIH, is also known as preeclampsia. It is the onset of blood pressure greater than 140/90 and proteinuria after the 20th week of gestation. This can have significant effects on both the mother and fetus. This degree of hypertension produces generalized vasospasm in the mother, which precipitates decreased circulating blood volume and activation of clotting factors. As a result, there is decreased perfusion to her kidneys, liver, and brain. Placental perfusion is also diminished so that the fetus may be compromised. The exact etiology of PIH is unknown, but autoimmune disorders, blood vessel abnormalities, diet, and genetics may play a role in its development. There are some recognized risk factors, however. First pregnancy, multiple fetuses, and a prolonged interval between pregnancies may contribute to PIH, as can maternal obesity and history of diabetes, chronic hypertension, and/or kidney disease. In addition, teens and women over age 35, mothers of African American heritage, and those with a history of preeclampsia in the family also raise the chance for its appearance. Symptoms of PIH include blood pressure greater than 140/90, as well as severe headaches and changes in vision, such as blurring, photophobia, or temporary loss. There may also be upper abdominal pain, usually on the right side under the ribs, nausea and vomiting, dizziness and irritability. In addition, sudden weight gain, typically more than 2 pounds in a week, and decreased urine output are commonly seen. Swelling of the face, hands, ankles, and feet may be apparent. However, this is not a definitive sign. Blood pressure of 160/100 or higher on at least 2 occasions, at least 6 hours apart, is classified as severe PIH. Other signs and symptoms of this condition include those of preeclampsia, plus proteinuria of at least 5 grams in a 24-hour collection sample, pulmonary edema, cyanosis, oliguria, persistent headaches, and thrombocytopenia. Other symptoms of severe preeclampsia include tachycardia, tachypnea, altered mental status, neurologic deficits, hyperreflexia, clonus, and papilledema. Women must contact their providers with the first appearance of any symptoms of preeclampsia, such as severe headache, visual changes, pain in the upper right quadrant of their abdomen, dizziness, irritability, significant weight gain, or decreased urine output, as well as signs of severe PIH, including neurologic changes or negligible urine output. The provider will check the woman's blood pressure and weight. She will also look at the face, hands, ankles, and feet to note any edema. In addition, she will assess the mother's neurologic status by evaluating mentation, looking into the eyes for signs of papilledema, and observing for clonus and hyperreflexia. Labs will be drawn and evaluated for platelet count, as well as kidney and liver functions. Urine will be assessed for presence of protein. It is critical that hypertension be managed as quickly as possible, as there are serious maternal sequelae that may arise if it remains untreated. The mother may suffer from diminished amniotic fluid, placental abruption, disseminated intravascular coagulopathy, liver rupture, renal failure, stroke, or death. In addition, the fetus may be compromised. There are several complications associated with PIH. One is the development of eclampsia. This occurs when the mother has a seizure that is induced by extreme hypertension, as blood pressure greater than 160/110 will prevent adequate blood flow to the brain. These convulsions begin as facial tics that soon evolve to generalized tonic-clonic seizures that last from 60 to 75 seconds. They are followed by a postictal period. Management of eclampsia includes hospitalization and administration of antihypertensives such as hydralazine. Seizure prevention is a high priority. Therefore, anticonvulsants are given. Magnesium sulfate is the drug of choice. It will be necessary to carefully monitor the woman and fetus during administration of magnesium sulfate because of its side effects. They include flushing, headaches, nausea, vomiting, blurred vision, and sudden drop in blood pressure. In addition, at toxic levels, it can cause respiratory depression, pulmonary edema, and even cardiac arrest. Mothers on a magnesium sulfate drip must have their vital signs taken every 15 to 30 minutes, as their respiratory status may decline or they may become hypotensive. In addition, nurses should assess the woman's mental status and deep tendon reflexes, as they may diminish. Other medications to control seizure activity include benzodiazepines and phenytoin. Non-pharmacologic management of the mother with eclampsia include her resting on her left side to avoid uterine pressure on her great vessels, drinking lots of water, and decreasing salt intake. In addition, her room should be dark and quiet so that environmental stimulation is kept at the minimum. Another complication of PIH is HELPP syndrome. This mnemonic stands for hemolysis of red blood cells, elevated liver enzymes with LDH greater than 600 units per liter, and AST more than 70 units per liter, and platelet count less than 100,000 per liter. It occurs in about 10 to 20% of women with preeclampsia or eclampsia. Signs and symptoms are consistent with preeclampsia. The diagnosis is based on the abnormal lab values. Maternal sequelae of HELPP are related to severe hypertension, which can reach over 160/100. They include intracranial hemorrhage, ruptured liver, disseminated intravascular coagulopathy, and pulmonary edema. Proteinuria and oliguria may occur as well. Fetal well-being may also be compromised, as there is a risk of placental abruption, intrauterine growth restriction, premature delivery, and death. Management of HELPP includes hospitalization, bed rest, and the administration of antihypertensives such as magnesium sulfate. Blood transfusions may be needed for thrombocytopenia. The only definitive treatment for PIH and its complications is delivery of the fetus. If there is a chance that the baby will be delivered preterm, corticosteroids are administered to the mother to enhance fetal lung development. If the woman is at least 34 weeks and her condition is stable, labor may be induced. However, delivery must be done immediately if the mother's diastolic blood pressure is over 110 or over 100 for 24 hours. If she has symptoms of HELPP, severe headaches, abdominal pain, reduced urine output or proteinuria, or if she shows signs of pulmonary edema or kidney failure. Fetal compromise is another reason for rapid delivery, usually via cesarean. Preterm delivery is birth of the fetus between 20 and 37 weeks. Prematurity is the leading cause of neonatal morbidity and mortality. Those babies who survive need specialized care in neonatal intensive care nurseries, sometimes for months. Often they have sequelae that impair their neurologic, intellectual, sensory, physical, and emotional growth and development. Cost of the care of these babies in the United States alone is over $26 billion annually. While the cause of some premature births is undetermined, there are known maternal risk factors for its occurrence, including some medical conditions such as diabetes, chronic hypertension, or clotting disorders. In addition, the mother being severely over or underweight may precipitate an early birth. Reproductive issues like uterine or cervical malformations, fibroids, in vitro fertilization, short time between pregnancies, or previous early delivery can also contribute. Other causes include vaginal bleeding and uterine infections. In addition, multiple fetuses or fetal birth defects such as hydrocephalus or spina bifida may either precipitate or mandate early delivery. The woman's lifestyle may contribute to prematurity as well. If the mother has had no or late prenatal care, smokes, drinks alcohol, or uses recreational drugs, is exposed to toxins or pollutants, or is under severe emotional, social, or economic stress, she is at risk to deliver her baby early. For high-risk women, interventions to prevent preterm birth can be initiated early in pregnancy. Progesterone gel is prescribed for mothers with a short cervix for use between 20 and 37 weeks. A new drug, 17-hydroxyprogesterone caproate, may be used to reduce the risk of delivery before 37 weeks in women with a history of at least one spontaneous preterm birth and with a current singleton pregnancy. Some mothers may unexpectedly go into labor early. They should immediately contact their healthcare providers if they experience any vaginal bleeding, leaking of amniotic fluid, increased pelvic pressure, onset of regular contractions, or notice a change in fetal activity. If preterm labor is suspected, the provider will evaluate the mother's vital signs and perform a pelvic exam to assess the amount of cervical dilation and effacement. The mother will also be observed for contractions using an external monitor. Lab tests will include a CBC, UA, as well as urine and cervical cultures. Fetal assessment is performed by evaluating its heart rate to assure it is receiving adequate oxygen and blood through the placenta. Often bed rest is advised with the woman lying on her left side. If she has an infection, antibiotics should be initiated. If perfusion to the fetus is compromised, she should be hospitalized with external fetal monitoring and given supplemental oxygen and IV fluids. Tocolytic medications are administered to hospitalized mothers who remain in premature labor between their 23rd and 36th week of pregnancy. These drugs are used to delay the delivery for at least 48 hours so that corticosteroids can be given to enhance lung development of the fetus. Magnesium sulfate is the drug of choice as it slows uterine contractions. Mothers will have to be monitored carefully during its administration for the appearance of side effects. Another medication that may be used with premature labor is indomethacin, an NSAID that blocks the production of prostaglandins, which are hormones that contribute to uterine contractions. It can be administered before 31 to 32 weeks to delay labor for 1 or 2 days. The goal for the mother in preterm labor is to provide supportive care and delay delivery as long as possible using interventions that are safe for both her and her baby. In conclusion, there are many complications that can occur during pregnancy. The mother should be aware of the symptoms of these pathologies, so if they appear, she can contact her provider immediately, as early identification and prompt treatment may save her life and reduce the risk of disability or even death of her baby.